warm environment of their house. I know it's chilly out there and everyone's preparing for Thanksgiving. And again, I appreciate your time. And I'm coming to you from Carrollton, Georgia, from the offices of West Georgia Urology. And my presentation this evening will be based on the slides that are in front of you. I'll probably do this in about 25 minutes or less, and then we'll have some time for questions. So, certainly you're on this webinar tonight because it piqued your interest. And, some of the questions that you may be asking is, will I ever regain control again? Is it the normal part of the aging process for me to be leaking urine or having fecal incontinence? And the answer for that is certainly it's not. And there are ways to help most people out there with urinary problems. Can you go on a date again? Sure. Attend an outdoor celebration without worrying about where the bathroom is or having an embarrassing moment? Yes. Can you get a job that requires you to be, on the platform of a factory for more than 30 minutes before you have an urge to go? Yes. You won't have to be afraid to leave your home again. And hopefully the bathroom will not be the most thing on your mind and the most embarrassing thing. What we're going to be talking about today is understanding bladder and bowel control and basically how we treat it, what the treatment options are, including, the InterStem device and other options as well. So you can see on the left or the right side of your slide that 17 million people in the United States have asthma. More than double, have issues with overactive bladder. 37 million Americans, or 1 in 6 adults, have the diagnosis of OAB, or overactive bladder. 1 in 12 adults in the United States, over 20 million Americans, have a diagnosis of fecal incontinence, where they have poor control of their stool or their feces. And you can see the numbers. 12 million people have problems with vision. And look how many more people have problems with fecal incontinence and overactive bladder. So what is the normal? What is normal and what isn't normal? Well, urinary and bowel incontinence are not a normal part of aging, as I mentioned before. Do these things sound common to you? Frequent accidents, getting the have to go now feeling, that sudden urge of urinary urgency, or you're going to begin to leak urine, planning most activities around the bathroom, shopping, driving, taking road trips, monitoring how much you eat or drink. And what I hear a lot from patients is it doesn't matter, I can drink nothing and I will still have this urge episode. And people limit what they eat and drink because they don't want to have accidents. Are you using pads or protective garments? Are you spending a lot of money on those devices? Yeah, they're very expensive. If so, your body is trying to tell you something. So how does bladder control work? Well, you have kidneys that produce the urine. They come down 2 tubes into the bladder. The tubes that connect the kidney to the bladder are the ureters. When the bladder is about half full, it stimulates nerves in the brain and then sends signals from the brain to empty your bladder. The bladder-brain communication is essential for bladder control. And what happens is communication breaks down, and that will cause bladder control issues and problems. Similar with bowel control, the digestive system pushes food through the intestine. When the rectum is full, it stimulates the nerves, sends messages to the brain, and then the nerves signal your brain to relax the anal sphincter muscles, and then you have a bowel movement. The bowel-brain communication is essential for bowel control. Communication breakdowns could cause bowel control problems. So what causes incontinence? So many things. Usually, it is an aging process. In women, it's a lack of estrogen. In men, it's a combined factor with the bladder, nerves from your back, prostate glands. Daily habits can cause worsening incontinence. Drinking a pot of coffee a day, having a gallon of tea a day certainly can impact urinary incontinence. Medications or supplements you take can have factors that involve it. If your physical mobility is reduced, if you're pregnant, childbirth can cause incontinence. History of radiation for different cancers, or even pelvic floor injury can all cause urinary incontinence. So the three common bladder control problems are broken down into stress incontinence, urinary retention, and overactive bladder. And we'll go through each one of these. So stress incontinence is leaking urine when you sneeze or cough, laugh, or do any kind of exercise, bending, or lifting. Leaking when you climb stairs or even when you stand up. It's all going to cause you to have an accident. And that's called stress incontinence. Again, it's leaking with some sort of stress, a sneeze, a cough, bending, or exercise. Urinary retention is a feeling of the inability to fully empty the bladder. Symptoms could be a weak or dribbling stream. Some men and even women need a catheter to actually empty their bladder, and that's called intermittent catheterization. Patients can't tell or don't have a sensation that the bladder is ever full. What is OAB, or overactive bladder? Well, that's really the essence of what we're talking about tonight, and that's urge incontinence. It's going to the bathroom or leaking urine before you reach the bathroom. Frequent leaks, even after drinking a small amount of liquid, when you're hearing or touching running water. I hear this commonly when you're at the gas station and you hear that liquid gas going into the gas can. That can cause a bladder contraction. People who are coming to their house and put the key in the door, and all of a sudden they get that sensation that they have to go and they begin to leak. These patients with overactive bladder and urge incontinence are using pads on a continuous basis, 1, 2, 3, 4, many pads a day. You'll have frequent uncontrollable urges to go. Some people will have such frequency that they will go up to 8 times a day, many times at night as well. And you'll always feel a sensation at times that you never completely empty your bladder despite going. Chronic fecal incontinence is a recurring condition with frequent bowel accidents. There's this urge incontinence as well, and the inability to resist the urge to defecate. And then there's passive incontinence, which is the inability to feel when you actually need to go and have a bowel movement. Very common problems. The good news is that there are treatments that get you back to living life. So there are many ways to treat overactive bladder and fecal incontinence and get back to living a normal life. First, the diagnosis, and that's why you have to come see a specialist like a urologist. We can talk about lifestyle or dietary changes. So certainly if I see a patient who's complaining of frequency, urgency, and their dietary habits include a pot of coffee a day or a 6-pack of beer or anything that normally would increase the amount of urine being produced, those are simple dietary changes. There are certainly a segment of the population who need no other therapy besides just changing how and what they drink or eat. It's pretty simple, but sometimes people don't even realize it. Then there's oral medications. We'll talk about that. And then there's, of course, advanced therapies. So simple solutions like I just mentioned can help some people, but may not work well with others. Like I said, diet has a very big impact. Physical therapy can sometimes help control some of the lower pelvic muscles. Those are known as Kegel exercises. They are effective usually with stress urinary incontinence, when you cough or sneeze, and that's when you leak. Those physical therapy techniques tend to help that more so than with urge incontinence. Oral medications are certainly very, very common. It is the first line of therapy, meaning it's usually the first thing we would give a patient after behavioral modification. After we tell the patient to stop drinking a pot of coffee a day, if that doesn't help, and if they're not drinking a pot of coffee a day, you usually start with an oral medication. There are 2 classes of oral medications now available. One are anticholinergics. Some of the common names of anticholinergic medications include Vesicare, Detrol, oxybutynin, Ditropan. All of those medications, some of the newer ones not as much as the older ones, they can cause dry mouth and constipation as the number 1 and 2 side effect. Some people will get some blurry vision from them and other symptoms. Another class of medication are not the anticholinergics, but they're more specific to the bladder, and they really don't cause many of the side effects discussed just now. One of the newest medications is Gemtesa, and the other one is Myrbetriq. The thing with medications is, first of all, about 72% of people said they stopped taking bladder medications within 6 months. And that's usually they run out of their supply, they're not sure it's really working, and they have side effects that they don't like. So they basically go off the medications and they just live with it, which is not a great answer. What are the advanced therapies? Well, if conservative treatments don't deliver the results you expected and the medications are not something you want to stay on, I do want to mention one thing about the anticholinergics. There is a very large study that was published 3 years ago in the New England Journal of Medicine that showed that patients who are on anticholinergics, and again, those are Vesicare, Ditropan, Detrol, Sanctura, oxybutynin, are the names of the common anticholinergics. Patients who are on it for 3 years or longer have a 50% increased chance of developing dementia. That is a very powerful study and a very scary study. And when I talk to patients about starting medications, either I will start them on the newer class of medications that apparently don't have those long-term consequences. And again, I say apparently because as we all know with all medications, how long have they been studied for? How many patients were in the study? And what we find over time, I've been doing this for 24 years now, we find that medicines that were thought to be safe for years and years and years, all of a sudden come out with a study showing that they're not safe. Perfect example are the anticholinergics that I just mentioned with a 50% increased chance of developing dementia. So if medications don't work, if medications scare people, we have other ways to control both bladder and bowel control. And that's with the Medtronic InterStem systems, and we'll go over all those options. One option that is not an InterStem, but is not a medication that is an oral medication, is called Botox. So Botox was FDA approved probably close to 12 or 13 years ago for injection into the bladder. And it's the same Botox that's used in cosmetics to make wrinkles go away. And basically, it's a neurotoxin, which is a fancy word for it paralyzes the muscle of the bladder. If it paralyzes the muscle of the bladder, it makes the bladder not overactive and will control a lot of the symptoms related to overactive bladder. This is not treatable. This does not treat fecal incontinence, obviously. This is just for overactive bladder. It's done in a 5-minute procedure in the office. There's a local anesthetic that's instilled into the bladder, and the patient tolerates it quite well. It doesn't begin to work for about 5 to 7 days. There's a very, very small chance that it creates a potential need to self-catheterize, which basically means that the Botox was so effective that the bladder can't squeeze the urine out and the patient will need to catheterize. That is an extremely rare complication at much less than 1%. The bad news about Botox is if it works, it needs to be repeated on a regular basis. So most Botox will last anywhere from 3 to 6 months, and then it needs to be retreated and another procedure needs to be done. And there's been a survey that showed that 51% of patients stop after 2 treatments. So it's effective, but it has to be repeated. And I think what happens over time is patients just don't want to go through another procedure and another procedure, and that's why more than half of patients stop after the second treatment. So PTNM, which is a neurosystem, is a minimally invasive, safe, effective therapy. It will reduce urgency, frequency, and urinary incontinence. It will restore bladder function by stimulating the tibial nerve. That's a nerve found in the lower leg that if you stimulate that nerve through the neuron system of the body, it will help control some of the urinary urgency and frequency. This, again, does not treat fecal incontinence. It's delivered during a 30-minute in-office session. It's painless. but you have to do it 30 minutes for 12 weeks, followed by monthly maintenance sessions for potential long-term relief. My experience with this from a personal perspective, not a personal perspective, but from patients who have used it, is it works, but it's not great. And you have to come to the office 30 minutes for 12 weeks for you to be able to see any results. But certainly for patients who are adverse to any kind of invasive procedures, this is definitely the way to approach it. So sacral neuromodulation, or the Medtronic InterStem system, it corrects the communication pathway between the bladder, bowel, and restores bladder and bowel function. So essentially, the way this works is pretty simple. The nerves that come out of the very low back are the nerves that control your bladder as well as your bowel function. If you're able to stimulate these nerves, which the Medtronic system does with a neuromodulation system, the nerves will then control the bladder and control the bowel so that you don't have leakage anymore. The nicest thing about the InterStem device is there's nothing done that's permanent at the very beginning. So we do a test, and it's called a test phase or a test. And basically that's done in the office. There's no general anesthetic given. You lie on your stomach. A small amount of lidocaine or novocaine is given into the low back. With a needle, we're able to locate the exact spot of where that nerve that controls the bladder or the bowel function comes. We find those nerves and we place a small wire and basically touch those nerves. We then hook that wire up to a small little external device, I call it a pacemaker, and that's taped to your skin. So the only thing that was done with probably about a 10-minute procedure are two small wires that are now touching the nerves that control your function, and that's hooked up to an external pacemaker. You then go home from the office. You can resume normal activities. You just have to make sure you don't tear out or rip out those little leads. And within 5 to 7 days, you'll come back to the office. Most people will have a great result from that test phase. If the test phase is successful, your fecal incontinence has been helped tremendously. If your urinary incontinence has been helped, you have less urge episodes, less leakage episodes, then we proceed to a permanent implant. So the implant is then done in the hospital, requiring a general anesthetic. The implant basically is the same as the test, but it's a more permanent device. So a single wire is then used to be placed into the low back area, stimulating the nerves that control your bladder and bowel function. That wire is then hooked up to this device that is seen right here. This is the non-rechargeable and a rechargeable device, and we'll talk about that in a second. The wire is hooked up to this, and this is put in through a very small, maybe 2-inch incision in either the right side or the left side of the buttocks. You won't feel it when you put a belt on. You won't feel it when you sit if it's properly placed. This device is controlled by basically a cell phone remote control that has you and me as the clinician able to change programs and increase or decrease the control of the bladder or the bowels. These are MRI compatible, which means that in the past, we weren't able to have an MRI after you had one of these devices placed surgically. Now these are all MRI compatible, so you could have an MRI, no problem. This device here, the non-rechargeable device, will last you anywhere up to about 8 years. This is a rechargeable device that has to be recharged with an external charger. This device can last well over 10 years. So some people would like to recharge their device and have a longer lifespan. Some people don't want the hassle of always having to remember to charge their device and just put this one in. So, we say yes to the test. There's very little downside to the test. Simple test starts at your doctor's office as an outpatient center. This is sort of what I just said, but I'll read it anyway. A lead where a thin wire is inserted in the upper part of your buttock. The lead attaches to a small external device worn discreetly under your clothes. Stop, start, or adjust therapy with an easy-to-use programmer. Go about your regular activities for 3 to 14 days. Track your symptoms and see if they improve. So 89% of people using Medtronic bowel control therapy experience long-term success. It 100% improves your quality of life. You know, there's nothing perfect in this world, but this is a very effective, safe, non-medication way of controlling an extremely embarrassing problem in a very good way. 76% of people achieve success with SNM for bladder control compared to 49% for medication. So it's certainly, like I said, it's not 100%, but it's very effective and it's better than medication. So is this therapy right for you? You may be a good candidate for Medtronic bladder or bowel control therapy delivered by the InterStim system if you have significant symptoms of OAB, or if you have urinary retention. It says you're non-obstructive, and that's something that the physician as a urologist could determine, or specifically if you have fecal incontinence. You've tried lifestyle changes, you've tried medicines, nothing has helped you. You're over it. Your quality of life is completely disrupted by urinary or fecal incontinence. These treatments that you've tried in the past don't give you relief that you want, then you're ready to talk to me about the InterStim device. So this is, I'm not living in the bathroom, I'm living my life. These are real patients. And I'll give it back to Jackie at this point.
Hey guys, thank you so much for joining, and thank you, Dr. Rauch, for presenting tonight. Guys, if you want to make an appointment, the phone number is right here. Make sure you write that down. And then there's also our website if you guys are not a local patient, but I think most patients are local. So if you want to make an appointment, just call this number. Make sure you write it down. We also have a poll that we're doing at the end of this, so we want you to make sure you fill out the poll, and then we're going to answer some questions. So if you have any questions, make sure you type them in the Q&A box, and then we're going to have Dr. Rauch answer some of those.